Chapter 24 of your Immunology textbook covers laboratory diagnosis of HIV infection. So previously in Chapter 19, we talked about the various primary immunodeficiencies, which are inherited disorders. This chapter covers one of the major causes of secondary immunodeficiencies, HIV. So we'll be discussing the course of HIV infection and how to diagnose it. We'll talk about an introduction of human immunodeficiency virus in this chapter, the modes of transmission, as I mentioned, the characteristics of the virus itself, the virus and the interactions with the immune system, and then the clinical course of HIV infection. We'll also touch on treatment options and prevention, along with laboratory testing for human immunodeficiency virus. In particular, talking about screening and diagnosis, algorithms, disease monitoring, and then mentioning testing of infants for HIV. As I'm sure most of you are familiar with, HIV is the causative virus of AIDS. So AIDS is acquired immunodeficiency syndrome. And there are two different strains of HIV, HIV 1 and 2. They're genetically related, but they're distinct viruses. HIV-1 is the cause of most HIV infections worldwide, and it consists of 4 groups, M, O, and P, with the group M being the major group that's the cause for the majority of HIV-1 infections. In the group M, there's 9 subtypes, which they're designated subtypes A, B, C, D, F, G, H, J, and K. HIV-2 is the other strain of the virus, and this one has originated in West Africa and is known to cause fewer cases of HIV, and is usually isolated in the West African area of the world, whereas HIV-1, as I mentioned, is seen worldwide. So the transmission of HIV occurs through one of 3 major routes. One being sexual contact, so the second contact with blood or other body fluids, and the third way is perinatally. So the majority of HIV infections have occurred through sexual contact, through the exchange of body fluids. The second route of transmission through IV drug use by exposure to infected blood or body fluids occurs mainly through the sharing of contaminated needles. Less frequently, HIV is transmitted through blood transfusions, the use of clotting factors by hemophiliacs, and then also the possibility of exposure through occupational injuries with needle sticks or other sharp objects. The third route of perinatal transmission from infected mother to the fetus or infant can occur either during pregnancy by the transfer of blood at the time of delivery, or it can be transmitted through breastfeeding in the breast milk. The human immunodeficiency virus is classified as a retrovirus. It belongs to the genus Lentivirinae and of the virus family Retroviridae. HIV is classified as a retrovirus because it contains RNA, or ribonucleic acid, as its nucleic acid, and also the enzyme reverse transcriptase that transcribes the viral RNA into DNA. HIV contains 2 copies of single-stranded RNA. It's surrounded by a protein coat known as a capsid, with an outer envelope of glycoproteins embedded in the lipid bilayer. HIV is a spherical particle, 100 to 120 nanometers in diameter, and it contains an inner core with 2 copies of single-stranded RNA, as mentioned previously. It's surrounded by a protein coat known as a capsid and an outer envelope of glycoproteins embedded in a lipid bilayer. The glycoproteins surrounding the spherical structure are knob-like, and they're involved in the binding process to the host during infection. The HIV genome contains 3 principal genes. The GAG gene, GAG, denoted here in blue, this codes for the nucleocapsid and core proteins such as the protein 24 or the P24. The POL gene, POL, in the light purple, codes for enzymes important for the virus, including reverse transcriptase. And the ENV gene codes for viral envelope proteins. So these include glycoprotein 160, which is cleaved into glycoprotein 120 and 41. The rest of the genes in the HIV genome code for proteins that regulate the expression of other genes and regulate viral replication and infectivity. The replication of HIV occurs in several steps. The first thing that needs to occur is the virus needs to attach to the host cell. The main target of the HIV virus are CD4 T helper cells. CD4 is present in high density on the T helper cells and in lower density on other cells, such as macrophages, and it serves as the main receptor for HIV by binding to the glycoprotein 120. A co-receptor is required in order for fusion to occur. Chemokine receptors, such as CXCR4 associated with T cells and CCR5 associated with macrophages, are co-receptors required for entry because they promote the fusion of the HIV envelope to the host cell membrane. After fusion, uncoating, or removal of the viral protein coat, this exposes the HIV genome, and then reverse transcriptase can convert the viral RNA to complementary DNA. As the double-stranded DNA is then synthesized, it becomes integrated into the host genome as a provirus. The provirus can then remain latent for a long period during which viral replication does not occur. Eventually, expression of the HIV gene is induced when the host is activated by cytokines or binding to antigen. These genes then code for viral RNA and proteins, which are assembled into viral particles, and in turn acquire their outer envelope when they bud out of the host cell membrane. The cycle can then be repeated as these intact HIV virions go on to infect new host cells. The same types of immune responses that are elicited from other viral infections are stimulated against HIV. The immune responses include innate defenses, humoral antibody production, and cell-mediated immunity. The innate immune response includes natural killer cells mediating cytolysis of HIV-infected cells. Dendritic cells also stimulate release of cytokines that have antiviral effects. Antibody production occurs and is detected by 6 weeks after infection, and antibodies may be produced later to prevent HIV from infecting host cells and participate in antibody-dependent cell-mediated cytotoxicity. T cells and cytolytic T cells are involved in the cell-mediated immunity. The T cells produce cytokines with antiviral activity, while the cytolytic T cells destroy HIV-infected host cells. HIV is a challenging infection because it's developed several escape mechanisms that help it evade the host's immune responses, and it allows the virus to persist in the body. Genetic mutations rapidly occur, generating new viral mutants with altered antigens that help the virus persist. HIV can downregulate expression of MHC1 molecules on infected host cells, and it can survive as a latent provirus for prolonged periods. HIV's genetic diversity hinders the ability of the host to mount an effective immune response, whereas the proviral state allows HIV to be undetectable and unable to replicate and induce immune responses. As was mentioned in the stages of viral replication, the CD4 T-cells are the prime targets of destruction, and with that, it results in reduced effectiveness of antibody and cell-mediated immune responses. HIV causes a chronic infection that's characterized by progressive decline in the immune system. Although the manifestation of the disease varies in individual patients, the infection typically progresses through a clinical course that begins with a primary or acute infection, followed by a period of latency that eventually culminates or ends with AIDS, the acquired immunodeficiency syndrome, if left untreated. Symptoms of the primary stage usually appear 3 to 6 weeks after the initial infection and then resolve within 7 days to a few weeks. Many patients may even be asymptomatic during this stage, but during the primary infection there's high levels of viremia, and there's also a decrease in the CD4 cell number. During the clinical latency phase, the levels of virus circulating through the bloodstream decrease and CD4 T cells numbers increase. During this latent stage, there's an absence of clinical symptoms. In untreated individuals, HIV infection can then progress to AIDS. At this stage, there's a resurgence of viremia and a decrease in the CD4 T cell numbers. Once the patient reaches the AIDS phase, there's usually profound immunosuppression with appearance of life-threatening opportunistic infections and malignancies. Treatment of HIV infection involves supportive care of associated infections and malignancies, as well as administration of Antiretroviral Therapy, also known as ART. This type of therapy suppresses the virus's replication. Several classes of antiretroviral drugs have been developed to treat HIV infection, and they include drugs that block various steps of the replication process. They include nucleoside analog reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease, integrase, fusion, and entry inhibitors. Antiretroviral therapy is most effective when combined. This combined therapy is known as CART, and it reduces the chances for drug resistance to develop. It significantly improved the quality of life of HIV-infected persons, increasing the survival rate to ages of 50+ years old. ART can also be administered to pregnant women along with newborns born to HIV-infected mothers. In addition, it's used to prophylactically prevent HIV infection to those who have been potentially exposed, such as healthcare workers with needle stick injuries. Although antiretroviral drugs and CART therapy have significantly improved morbidity and mortality in patients infected with HIV, they can't be considered cured of AIDS. The HIV virus is still harbored in lymphoid organs throughout the body and will progressively eventually destroy the immune system. Other approaches for dealing with HIV have been directed towards preventative measures of the initial infection. Some of these measures include screening blood or organ donors for HIV, education of the general public or high-risk populations on the transmission of the virus, along with safety measures, education for healthcare workers that can potentially be exposed to the virus, along with prophylactic treatment for healthcare workers who have potentially been exposed to the virus. The ultimate or the last means of preventing HIV is the development of an effective vaccine. A lot of research has been done in this area, but it's been a difficult task for many reasons, including the fact that the virus can rapidly mutate and escape immune recognition. So there's also no ideal animal model to study the vaccine. The laboratory plays an important role in establishing the initial diagnosis of HIV, along with monitoring known patients for their response to antiretroviral therapy. Over the past years, the CDC and Association of Public Health Laboratories have developed algorithms that use a combination of laboratory tests performed to screen for the presence of HIV infection and resolve any discrepant results. On the next few slides, we'll briefly touch on different laboratory testing for screening and diagnosis, and also talk about the previous algorithms that were used along with the current algorithm for HIV screening. Other tests we'll look at are those that are used for disease monitoring, such as CD4 T-cell counts, HIV viral load, and drug resistance testing. We'll also briefly discuss testing of infants, which is typically done for mothers of unknown HIV status or mothers who have not received any prenatal care. Serological tests for HIV antibody are used in the initial diagnosis of HIV infection because most individuals develop antibody to the virus within 1 to 2 months after exposure. Various serological methods have been used to detect HIV. Standard screening methods for antibody to HIV have involved enzyme-linked immunosorbent assay, or ELISA methodology. In 2004, the previous algorithm, or the recommended algorithm that was used, was a rapid HIV antibody test using the ELISA or EIA methodology. This method was screening for HIV-1 and HIV-2 antibodies. Any positive results were required to be confirmed by HIV-1 Western blot. The antibody screening tests that were often employed were rapid EIAs, and they were typically lateral flow or flow-through immunoassays that produced a colorimetric reaction for a positive result. These tests are very rapid and produce results in a matter of minutes, and they're especially suitable in certain situations, such as in resource-limited settings in developing countries where expensive instrumentation and skilled personnel are not available. False positive results can occur with these rapid screening ELISA or EIA tests, and this is why positive results need to be confirmed by a more specific test, such as Western blot. The figure here shows an example of Western blot results. In the Western blot, antibodies directed against specific HIV proteins are detected. The patient's serum is then incubated with a test membrane onto which HIV proteins have been blotted after separation by electrophoresis on gel. A washing step is completed to remove any unbound materials, and then an enzyme labeled anti-human immunoglobulin is added. Following a second incubation and wash, a chromogenic substrate is added, and then bands to the proteins of specific molecular weight are visualized, such as in the figure on the right. On the left is showing an example of a negative Western blot where no bands are visible. The middle is an example of an indeterminate result. And on the right is an example of a positive result. In the positive Western blot, at least 2 of the 3 bands need to be present, and the bands that are indicated are the P24, GP41, and GP120 or 160. With that being said, and describing the Western blot method, This is, again, the previous testing algorithm. So the Western blot is actually no longer recommended for clinical use because it has an incidence of indeterminate results and insensitivity, technical difficulty, and also a long turnaround time of the test. In 2014, the CDC recommended that initial screening be performed with a combination immunoassay that detects antibodies to HIV 1 and 2, as well as the HIV 1 P24 antigen. So the previous algorithm we talked about was only detecting antibody. These recommendations apply to adults and children who are older than 24 months. There's actually separate recommendations for children younger than 2 years, as maternal antibodies may be present that are likely to confuse the interpretation of test results. With the current testing algorithm, any positive results with a rapid immunoassay that differentiates between HIV-1 and HIV-2 antibodies should be resolved using qualitative nucleic acid testing, or NAT, performed by PCR, or transcription-mediated amplification. These results are more accurate and are obtained more rapidly, 15 to 17 days, than with the previous testing algorithm. This newer testing algorithm allows for more rapid and accurate identification of HIV infection, which then makes it possible to begin treatment more quickly. Although the 2014 algorithm is highly sensitive in the detection of infection, it does have some limitations. The CDC will continue to evaluate its algorithm as additional tests become available for clinical use. Several manufacturers have developed commercial kits and instrumentation that are useful in screening blood products and in diagnosing and monitoring patients. Over the years, 5 generations of ELISA have been developed, resulting in improved sensitivity and specificity. We won't go through every generation, but we'll discuss the 4th generation briefly, which is the methodology incorporated in the current testing algorithm. As was discussed previously, the 4th generation assay can simultaneously detect HIV-1 and HIV-2 antibodies and the P24 antigen. Previously, separate immunoassays were used to detect the P24 antigen from the core of the HIV virion as a marker of early infection. The basic principle of the 4th generation HIV antibody antigen combination test involves the use of sandwich ELISA, or CLIA, in which patient serum is incubated with a solid phase, onto which synthetic or recombinant HIV-1 antigens, HIV-2 antigens, and monoclonal antibody to HIV-1 P24 have been attached. If the antibody to HIV is found in the sample, it will bind to the HIV-1 or 2 antigens, or both if infections are both present. If P24 antigen is in the sample, it will bind to the anti-P24 on the solid phase. Following a wash step to remove excess sample, a conjugate containing chemiluminescent or enzyme-labeled anti-P24 and HIV-1 and 2 antigens is added. After a second incubation and wash step, the appropriate trigger solution or substrate stop solution is then added, and the relative light units released or optical absorbance is measured. As described on the previous slide, this figure shows after the substrate stop solution has been added and the light units or optical absorbance is measured. If the results are then positive, they should be confirmed using a rapid enzyme immunoassay. More recently, 5th generation assays have been developed that provide more diagnostic information. One of these is a bead-based immunoassay that can detect both HIV antibodies and antigens, similar to the fourth-generation assays, but in addition, it can differentiate between HIV 1 and 2 infection. In the future, implementation of assays such as these may change the testing algorithm for HIV again. Once a diagnosis of HIV infection has been established, it's important to monitor patients over time to evaluate the effectiveness of their therapy. There's 2 laboratory markers that are routinely used to monitor patients with HIV infection for both the progression of the disease and also to guide their treatment. One of the important laboratory markers is the peripheral blood CD4 T-cell count, and this is considered to be the best indicator of immune function in HIV-infected persons. The second marker is the HIV-1 RNA level, or viral load, and this reflects a patient's response to therapy. Drug resistance testing is also performed to monitor patients with HIV. Enumeration of CD4 T cells in the peripheral blood play a central role in evaluating the degree of immune suppression in HIV-infected patients. These counts are the best indicator of immune function. Normally, the peripheral blood CD4 T cell count ranges from 450 to 1,500 cells per microliter. In untreated patients, there's a progressive decline in the number of CD4 T cells. The CDC classification system uses CD4 T cell counts to place patients into various stages of HIV infection, with the counts that are below 200 per microliter being categorized as having a stage 3 infection. The gold standard for enumerating CD4 T cells is immunophenotyping with data analysis by flow cytometry. With this testing, as we've seen before, peripheral blood is incubated with fluorescent labeled anti-CD4 and then analyzed. Significant declines in CD4 T cell counts that are monitored by immunophenotyping and flow cytometry over time may indicate a need to change the combination antiretroviral therapy or administer prophylactic therapy for certain infections. Quantitative viral load tests measure the amount of circulating HIV nucleic acid and play an important role in helping clinicians predict disease progression, monitor patient response to antiretroviral therapy, and guide treatment decisions. The amount of HIV RNA, or the viral load in a patient's plasma, reflects the natural history of HIV infection in that individual. HIV RNA levels become detectable about 11 days after infection and rise to very high levels shortly after, during the initial burst of viral replication. Typically, over a period of a few months, the viral load drops as the individual's immune system clears the viral particles from circulation and reaches a stable level of plasma HIV RNA. Viral load assays are based on amplification methods that increase the number of HIV RNA copies, so these are molecular-based methods. Several amplification methods have been developed for this specific purpose, including polymerase chain reaction, or PCR. The branch DNA assay, known as bDNA, and nucleic acid sequence amplification, also called NASBA, amplifies HIV RNA. Of the molecular assays used to monitor viral load, 2 kinds of PCR had been developed to detect HIV nucleic acid. The real-time PCR, also known as quantitative real-time PCR, was the first commercial assay licensed by the FDA for quantitative measurement of circulating HIV nucleic acid. The basic principle of quantitative PCR is to amplify a DNA sequence that's complementary to a portion of the HIV RNA genome. The other major method, the branched-chain DNA assay, involves amplification of the HIV target sequence. The branched DNA method is based on amplifying the detection signal generated in the reaction. These two methods are described briefly in the textbook, but we'll look at these further in our molecular course. As previously mentioned, the viral tests are used routinely to monitor the effectiveness of antiretroviral therapy in HIV-infected patients, and it plays an essential role in clinical management of these persons. Patients who attain lower numbers of HIV RNA copies per milliliter of plasma are more likely to achieve a longer treatment response. The optimal goal of therapy is to reach undetectable levels of HIV RNA. The U.S. Department of Health and Human Services recommends that plasma HIV RNA testing be performed before antiretroviral therapy begins to obtain a baseline value, and then testing should be performed periodically to determine the effectiveness of therapy. A change in viral load is considered to be significant if there's at least a 3-fold, or 0.5 log to the 10th increase or decrease in the number of copies per milliliter. A change in the antiretroviral therapy protocol is recommended for patients whose HIV RNA levels and CD4 T-cell counts reach critical values established by the AIDS Clinical Trial Group or the World Health Organization. This figure shows typical CD4 T-cell numbers and plasma viremia during the course of HIV infection in an untreated patient. The figure shows how monitoring these two parameters can be useful to evaluate immune status and viral load over time. The CD4 counts typically decrease rapidly, so these are pictured in blue at the onset of infection, and then rebound and decline more slowly during the latent period when the immune system is keeping the virus in check. At the onset of AIDS, CD4 T-cell numbers begin to decline to very low numbers. Plasma viremia increases rapidly at the onset, so this is seen in red, and then decreases to undetectable levels when the virus is being destroyed by the immune responses during clinical latency. At the onset of AIDS, viremia will increase as the virus becomes reactivated and destroys the immune system. Effective antiviral therapy results in prolonged latency periods with higher CD4 T-cell numbers and ideally an undetectable level of viremia. The last course of testing we'll discuss for patients infected with HIV includes drug resistance testing. The rapid replication of HIV can result in mutations that then enable drug-resistant populations to emerge during the course of antiretroviral therapy. To check for this issue, two types of methods have been developed: genotype resistance assays and phenotype resistance assays. Genotype assays are recommended by the U.S. Department of Health and Human Services before initiation of antiretroviral therapy in patients in whom combined therapy has failed, and in all HIV-positive pregnant women. The genotype resistance assays can be performed in clinical laboratory settings and involve HIV reverse transcriptase and protease genes from RNA in patient plasma amplified by real-time PCR. The products are then sequenced and analyzed with software for mutations. Results of this genotype testing are reported as either resistance, possible resistance, or no evidence of resistance. The phenotype resistance assays determine the ability of HIV from clinical samples to grow in the presence of antiretroviral drugs. These assays involve sophisticated technologies and are performed in specialized reference laboratories and are not routinely performed in clinical laboratories. Both genotype and phenotype assays require at least 500 to 1,000 copies of HIV RNA per milliliter in the test sample, and for the resistance virus to constitute more than 25% of the total HIV population harbored by the patient. Despite these limitations, antiretroviral therapy appears to be more successful in patients who have undergone drug resistance testing. The last type of testing we'll discuss in regards to HIV is that of infants younger than 18 months. Remember that IgG can cross the placenta during pregnancy, so maternal antibodies in infant serum can confuse serologic test results. With that, molecular methods are used for diagnosis. Nucleic acid tests for HIV should be performed in infants with known perinatal exposure at 14 to 21 days, again at 1 to 2 months, and then at 4 to 6 months of age. Positive tests should be confirmed by repeat testing on a second sample because false positive results can occur. Qualitative HIV-1 DNA PCR using infants' peripheral blood mononuclear cells is the preferred method. 2 or more negative test results at 1 month of age and older than 4 months of age provide evidence for the absence of HIV infection. Quantitative RNA assays may also be used but are not as sensitive as DNA assays for HIV. Serologic testing at 12 to 18 months of age may be used to confirm diagnosis. There has been increased emphasis on screening pregnant women for HIV because early detection is important because infants then have a better prognosis when combined antiretroviral therapy is started early on. So the major points discussed in this chapter are that HIV-1 is the cause of the majority of AIDS cases throughout the world, and HIV can be transmitted by sexual contact with contaminated blood or body fluids, and also perinatally. HIV is a retrovirus with 3 structural important genes, the GAG, POL, and ENV genes. The primary targets of the HIV infection are the CD4 T-cells and macrophages, with CD4 cells serving as main receptors for entry of the virus into host cells. Although the body mounts innate defenses and produces specific antibodies and cytotoxic T-cell responses against the virus, it's developed several escape mechanisms that are allowed to persist. There are 3 phases in the course of HIV infection, and these include primary infection, latency, and then AIDS. Treatment with combined antiretroviral therapy is recommended for all HIV-infected persons and has resulted in delayed disease progression, decreased mortality, and reduced perinatal transmission. Remember that there were several algorithms developed over the years for screening and diagnosis of HIV. The current CDC testing algorithm for HIV infection consists of screening by a 4th-generation immunoassay that detects both HIV-1 and 2 antibodies and the P24 antigen. Positive results are confirmed with a rapid EIA that distinguishes between HIV-1 and 2 viruses, and any discrepant results are resolved by nucleic acid testing. This current algorithm is more accurate and faster than the previous algorithm of ELISA confirming with Western blot. Remember, there's also now 5th-generation assays that are used to screen and detect HIV, so the current algorithm may change in coming years. And finally, patients with HIV infection are routinely monitored, and the 2 major markers are CD4 T-cell counts and viral load testing by molecular methods. And with that, molecular methods play an important role in resolving discrepant screening results, monitoring patient viral load during combined antiretroviral therapy, detecting antiviral drug resistance, and diagnosing infections in infants younger than 18 months of age.